Hello, this is Kim Jong-dul. Today's topic is the differential diagnosis for Class 3 malocclusion. Class 3 malocclusion patients tend to have unaesthetic profile because of protruded mandible, and thus many wish to receive orthodontic treatment. This is a patient with ODI 52, a PDI 99 CF 151, which indicate Class 3 high angle type. Due to Class 3 malocclusion, the upper incisors are labially inclined 129. The lower incisors are lingually inclined 73, and UOPE and POPE are flat. In this case, what should be primarily considered? Unlike Class 2 malocclusion, for Class 3 malocclusion, it first has to be decided whether to treat with orthodontic treatment only or surgical orthodontic treatment. Then in differential diagnosis, it can be classified into maxillary retrusion or mandibular prognathism, or non-extraction or extraction. Orthodontic diagnosis of Class 3 malocclusion is rather easy, because most cases can be treated with non-extraction approach or the extraction of third molars. Above all, it should be certain whether to accompany surgery or not. There are many factors to consider when deciding orthodontic treatment only or surgical orthodontic treatment. The first is patient's need. If the patient wants major aesthetic improvements, surgical orthodontic treatment is required. If not, orthodontic treatment only can be carried out. The next is clinician's ability. Clinicians should do their best even if the patient does not wish surgical treatment. Initial STO should be performed because the patients wonder how they would look after surgery. So it is advisable to discuss with the patient about the approximate change to facial appearance with initial STO photos. This patient has a protruded mandible, and the profile is improved in the initial STO. However, patients may not desire this change. Some patients have long lower anterior facial height, and the profile can be improved by surgery. First of all, if there is not much change in facial appearance, in the initial STO, only orthodontic treatment should be carried out. If aesthetics is improved, then let the patient decide to have surgery. Surgically combined orthodontic treatment is performed if the patient wants. However, the patient may not want to have surgery despite aesthetic improvement. In this case, the patient can be treated with orthodontic treatment only if possible. The biggest problem with only orthodontic treatment is even more linguversion of the lower incisors. Since teeth have to be aligned in an already large mandible, non-extraction treatment should be carried out if possible. During the course of treatment, the already lingually inclined lower incisors are likely to be further lingually inclined. This must be explained to the patients because they hope for post-treatment improvement and expect the incisors to be in a normal position. It is important to mention that the linguversion of lower incisors cannot be changed or can be worsened in only orthodontic treatment. Surgical orthodontic treatment can be largely divided into 3 steps: presurgical orthodontic treatment, surgery, and post-surgical orthodontic treatment. If surgery is performed first, it is followed by post-surgical orthodontic treatment. Then surgery can be classified as one-jaw surgery, double-jaw surgery, and with or without genioplasty. And the amount of presurgical orthodontic treatment can be determined depending on the type of surgery. Keep in mind that basically 4 to 6 months of post-surgical orthodontic treatment is needed. It is best to minimize presurgical orthodontic treatment, and there are 3 aspects to consider. 1. Extract the third molars 4 to 6 months before the surgery. For students, it is advisable to extract the third molars during summer or winter break, or immediately if the surgery is planned in the next break. 2. In Class 3 malocclusion, the lower incisors are already lingually inclined, and they should be labially inclined for decompensation by non-extraction treatment in the lower arch. 3. Upper premolar extraction has a large impact on the duration of presurgical orthodontic treatment. When deciding premolar extraction in the upper arch, not only the yawn to FH inclination, but also the transverse dimension should be evaluated. Like this, move the mandibular model posteriorly to make the canine key class 1. If there is not a significant problem in transverse dimension, it is advisable to treat with non-extraction approach if possible. However, if there is a scissors bite in the second premolar area, the upper first premolars should be extracted because the transverse dimension of upper arch generally decreases when the upper first premolars are extracted. Even if there is an upper anterior crowding, non-extraction treatment should be carried out. But if there is a transverse problem, the upper first premolars should be extracted. Many patients end up choosing only orthodontic treatment, and now it has to be decided whether to extract teeth or not. As you can see, this patient has a protruded mandible. The profile at edge-to-edge bite by retrusion of the mandible is evaluated. If edge-to-edge bite is impossible, the patient is asked to retrude the mandible as much as possible. In intraoral photos, anterior and posterior cross bites, upper anterior crowding, and no anterior crowding in the lower arch are observed. Facial appearance at edge-to-edge bite from both the side and front should be evaluated. At show bite, the mandible is protruded. But at edge-to-edge bite, the profile is improved. What does it mean if the aesthetics is poor at edge-to-edge bite? It indicates normal maxilla and prognathic mandible. The long mandible cannot be reduced by orthodontic treatment. Also, if LAFH is long, the aesthetics is poor at edge-to-edge bite. In Class 3 malocclusion, these are important factors in diagnosis. A. Capability of functional shift to edge bite. B. Familial history of mandibular prognathism. T. Lip seal. T. Profile at edge-to-edge bite. E. I pay a close attention to the development of zygoma midface, because many patients with retruded zygoma possess retrognathic maxilla. LAFH. As in Class 2 malocclusion and all the other malocclusions, combination factor is evaluated in differential diagnosis. Class 3 malocclusion can be either low-angle type or high-angle type. Combination factor is the sum of ODI and APDI. Since APDI is already higher than 85 in Class 3 malocclusion, CF higher than 160 indicates low angle, and CF lower than 155 indicates high angle. Class 3 low angle type is favorable to orthodontic treatment. On the other hand, in Class 3 high angle, even if the mandible is retruded and the maxilla is advanced, the treatment response is often disappointing. In skeletal pattern analysis, ODI, APDI, and CF are assessed. 1. The higher the APDI, the more severe the anteroposterior discrepancy. 2. 3. Then CF is evaluated to classify high angle or low angle. 4. Lastly, posterior available space PAS is assessed in conjunction with the eruption state of lower third molars. After skeletal pattern analysis, possibility of non-extraction treatment should be considered. It is important whether there is a crowding in the upper arch or the lower arch. In this patient, there is almost no crowding in the mandible. However, if the maxilla is retruded or underdeveloped, there is a high chance of crowding. In this case, non-extraction treatment should be carried out if possible. On the other hand, if there is a crowding in the lower arch, it is difficult to treat with non-extraction approach, and premolar extraction is likely to be needed. If the profile at edge-to-edge bite is poor, it indicates mandibular prognathism or long LAFH. And surgical orthodontic treatment should be taken into consideration. In growing patients, many orthodontists use chin cap for growth modification. I used to use chin cap as well about 3 decades ago and do not use it anymore now. The 3 options for growing patients are observation, installation of TPA and observation, and extraction treatment. In other words, growth modification is not attempted in these patients, and later they can be treated with extraction treatment or surgical orthodontic treatment. Likewise, adult patients can be treated with extraction approach or surgery. What does it mean if the profile at edge-to-edge bite is acceptable? It indicates retrusive maxilla or vertical deficiency problem. In growing patients with skeletal problem, face mask can be used in order to advance the maxilla. For dental problem, expansion or extraction of only the lower third molars can be carried out. In adult patients, if there is a severe crowding in the lower arch, the lower second premolars are extracted. Many orthodontists extract the lower first premolars in the treatment of class 3 malocclusion. However, the extraction of lower first premolars results in even more linguversion of the already lingually inclined lower incisors. Therefore, the basic extraction option for class 3 malocclusion is the extraction of both upper and lower second premolars. If the crowding in lower arch is not severe, non-extraction treatment is possible, or only the lower third molars can be extracted. This is the data from Couldem Dental Hospital. Among class 3 non-surgical treatment cases, 87 are treated with third molar extraction only, meaning that premolar extraction is not common. Only 13 are extraction cases, which are consisted of U77, late 8 extraction, U55, L55 extraction, and U44, L55 extraction. Keep in mind that the second premolars are extracted in the lower arch if needed. In U55, L55 extraction treatment of class 3 malocclusion, the upper and lower incisors are slightly retracted. The upper molars are moved forward, and then the lower dentition is uprighted. Here is the guideline for premolar extraction in class 3 malocclusion. If the lower anterior crowding is too severe, the lower first premolars can be extracted. If the upper anterior crowding is severe, the upper first premolars and lower second premolars are extracted. Nonetheless, keep in mind that basically the second premolars are extracted in both the upper and lower arches in class 3 malocclusion. To sum up, in class 3 malocclusion treatment, it first has to be decided whether to treat with orthodontics only or with surgery. In growing patients with maxillary retrusion, face mask can be used for growth modification. In non-extraction treatment, the third molars are extracted. For extraction treatment, if the current profile is acceptable, the upper second molars and lower third molars can be extracted, provided that the upper third molars are in good conditions. Otherwise, the second premolars are extracted in both the upper and lower arches. Further details of differential diagnosis and treatment of Class 3 malocclusion will be discussed in Master Course. Thank you for watching.